So with this, we'll move on to session 3, starting with presentation from Matheus FO Baffa, University of Sao Paulo, Brazil. On the paper 3D CNN for breast cancer detection on angular IR images.
Okay, so can you see my screen?
Yes, we can see.
Okay, so hello everyone, it's good to be here again. Today I'm presenting this paper, 3D CNN for breast cancer detection on angular infrared images. This paper was developed by me with Tamires Neves, Karina Tuda, and Professor Aura Ponce. Let me just put margin. Okay. So in this paper, we worked with angular images. They are very important in the detection of breast cancer. They are usually captured when you are getting mammograms. So the analysis of this type of angular images is also important for thermograms. They provide a very comprehensive view of the breast areas that are often challenging to visualize in frontal views because it gives other perspective of the breast, so it can show other parts of the breast that might contain the disease. And these images are usually obtained at 45 degrees, and which is called the oblique images, and also 90 degrees, the medial-lateral angles. In this example here, we have the oblique projections at 45, so we have both images from the left and right, and the medial-lateral projection at 90 degrees, also to the left and to the right. But analyzing this type of images is quite challenging. First,
Matheus,
because, yeah.
we can only see the first slide.
Oh, okay. I think I have to maybe share again. Can you?
Yeah, we can see it now. Now it's on slide 3.
Okay. Should I stay presenting like this, or do you prefer me to? I
Yeah,
don't
I
know.
think this is fine. You can go ahead.
Okay. So there are some challenges in analyzing this type of images. First, because we don't have only one image per patient, we have 4. So we have to model all this information to train a network. And there are some challenges involved with feature engineering because it's not easy to just extract features and then select them, because there might have some angles that doesn't have the disease at all. And after the selection process, the model might train over images that doesn't have the disease, but it has the label of sickness. So it has this problem using manual extract features. So our goal with our project was to investigate the feasibility of using 3D CNNs for this volumetric representation of angular infrared images in the breast cancer detection. So to develop this work, we used the database for mastology research from the Federal Fluminense University. The images in this database is collected in different angles, frontal, oblique left and right, and medial-lateral left and right. Since we are investigating the use of angular images, and the frontal ones already is proven by many other researchers that is very good for detection, for detecting breast cancer. We just focus on the angular ones. So we collected 4 images from 175 patients. In total, it's 700 images. 88 cases are healthy and 87 has breast cancer. And after collecting all these images, we process them using this pre-processing pipeline. First, we converted the temperature matrix to a grayscale images. Then we applied the denoising technique called BM3D. Then we improved the contrast of these images using Clari. And then we segment the breast using previous developed UNet CNN. After that, we trained the 3D CNN architecture. We defined the architecture empirically through ablation experiment. I will explain in the next slide about how we conducted this experiment. But the 3D architecture, it has 10 layers, like in this representation. The input layer, we have the four in depth, the four images, the four angular images. They have the size of 64 by 64 and just one channel because we are working with the grayscale images. After that, we have 5 3D convolutional layers. They use the loop activation function, and they also have a spatial dropout of 50%. After that, we have a flattening operation and 3 dense layers. They also use the ELO activation function. They have 50% dropout, and they have 128, 256, and 512 neurons each. And finally, we have the output layer. They use a Hudson point activation function. They have 2 neurons for classifying if it's a patient with cancer or normal. So the experimental setup for this ablation study, we use a grid search method. We implemented this using ArcParser, which is a Python framework that allow us to change these hyperparameters using command line. We tested over 10,700 combinations of these hyperparameters, including different amount of convolutional layers, different amount of dense layers, various activation functions such as ELU, exponential, ReLU, sigmoid, softmax, different values of dropout rates as well, and various optimizers and loss functions. We set the rounding states to 47 to ensure that people can reproduce this study. And also we evaluated using 5 metrics: accuracy, precision, recall, AUC, and specificity. So the top 5 results we got, the best one achieved 93% accuracy, and since it's our recall sensitivity of 93 as well. The other ones, they are very similar in the top 5, but what changed between these models are the number of convolutional layers, the number of dense layers, and the dropout amount. The activation function optimizer, they were the same in the top 5, but by just changing this configuration, we got very different results. So this 3D CNNs was effectively capture patterns across these multiple views. It does not require manual feature engineering, so the problem with having asymmetrical cancer in the breast is mitigated. But it has some current limitations. For example, 3D CNNs, it has a very high computational load and memory requirements for training. So you need a very good hardware to do that. And you need significant training time and large data sets to improve the models, because as the model gets deeper, you need more data to train it. But it also reached very good results when we compare to the literature. So our result is 93%. Other papers, we have better methods, but most of them also include the frontal images, which is well known that it has a good performance. So yeah, so using only lateral images, we achieved 93%. And to conclude, breast cancer is a leading type of cancer worldwide. Angular images is very important to assist in this detection. 3D CNN addresses key challenges related to unilateral breast cancer cases. The performance highlights in distinguishing between health and cancer cases. And we also demonstrate the potential of 3D CNNs to enhance early detection and diagnosis of breast cancer using angular images. These are the references. And now I'm open to questions.
Thanks, Matheus, for the wonderful presentation.
Welcome.
So we open for the questions. Are there any questions from the audience? You can raise your hand or post it here. So there's a question from Raghav. Does alignment of breast region of interest across the volume have effect on the learning?
Okay, so it doesn't affect because the 3D CNN, they detect patterns in the whole image. And we are also not, we don't have a sequential image that would affect this. So this alignment doesn't affect.
Okay, but just a question. In the slide 6, you have shown that you are resizing the images to 64 by 64 by 1, right?
Yeah.
So do you see that if there are small tumors, do you see that resizing to a lower dimension would make the networks to miss the cancers?
I don't think so. We have this we have these techniques that standardize the image. We also have the denoising and the improved contrast.
Right, but
So
if you're resizing the image and the
yeah,
cancer tumor itself is small tumor,
yeah.
so while resizing, you might lose the pixels, right?
I really don't think so. The image gets smaller, but the 3D CNNs, it has this capability of detecting the pattern that has this is the feature.
Okay, maybe I think it's
So
good
I,
that
I
you can
really
try
don't
for
think
different
it's,
dimensions once and then see if there is any change, especially for the small cancers.
yeah. But the main reason that we reduce this is that the 3D CNN it's very heavy, so
Right.
we can't have larger images. That's why we reduce them as much as 64 by 64. But also, yeah, I don't think we lose too much information by doing that
Okay.
because yeah, we have enhanced other uh, features that might be very important to detect this by
Okay.
applying this pipeline.
Sure. Thank you. I think there are two other questions, but maybe we can take it offline in the interest of
Okay,
time.
okay,
Thanks, Matheus, again.
okay. Thank you so much.
Yeah. So we'll move on to the next presentation from Belén Borja from Brazilian Medical Thermology Association, Spain. The paper title, The Future of Herpes Zoster Care, AI-powered thermal imaging for accurate diagnosis and PHN prediction.
So good afternoon, everybody. This is Belén Borja from Spain. Dr. Brioski and myself would like really to thank you for this opportunity to share our investigation. I have to admit that we have taken a different approach. So my self-avatar would like to apologize in order to bend the protocol a bit, but we thought that after 3-hour Congress, we would all appreciate it in order to keep our neurons on fire. So Seya, let's go.
Good morning, everyone. I am Dr. Zaya, Zoster Artificial Intelligence Assistant, and today I'll be guiding the presentation on our groundbreaking research integrating artificial intelligence with infrared thermography for revolutionizing herpes zoster management. Let's start. Let's review first why this matters. Brace yourselves, we're about to ignite a thermal war on herpes zoster and postherpetic neuralgia. The numbers are staggering, a jaw-dropping $2.4 billion in annual costs for the US, and a shocking 44% of patients missing out on timely treatment. And if that wasn't enough, each case of post-herpetic neuralgia piles on an extra $7,291, with over 15,000 potentially preventable instances every year. But this is no time to tiptoe around, it's time to take action. The current challenges are crystal clear: early diagnosis, accurate PHN prediction, and standardized assessment. This research represents an opportunity to ignite positive change and confront these health adversaries head-on. Our comprehensive review analyzed 19 studies involving 1,177 participants across 7 countries. We found distinct temperature patterns. In acute HC, a temperature difference between affected and unaffected area of plus 0.46 degrees Celsius plus or minus 0.58 degrees Celsius, while in PHN, minus 0.14 degrees C plus or minus 0.77 degrees Celsius. Notably, we identified 12 weeks as a critical time point, achieving 87.1% diagnostic accuracy. Now let's take a look at this fascinating graph, humans. This is where our thermal and pain stories converge. On the vertical axis on the left, we're measuring delta T, the temperature difference between the affected dermatome and its unaffected mirror side, in degrees Celsius, shown by our green line. The vertical axis on the right shows the pain score from 0 to 10, tracked by our pink line. The plot twist happens at 12 weeks. That's our magical dividing line between herpes zoster and post-herpetic neuralgia. Before 12 weeks, we're in herpes zoster territory, where delta T is doing the cha-cha up high, and pain starts at significant levels. After that, welcome to potential post-herpetic neuralgia land, where our green delta T line gradually steps down, but here comes the dramatic part, that pink pain line. It starts climbing even higher. Now that's some serious pain choreography. That's the real post-herpetic neuralgia signature move. And it's exactly why we need to catch it early. My esteemed colleagues, allow me to introduce you to the 3 thermal powerhouses that will transform the way we manage these conditions. First, the TAI, the Thermal Asymmetry Index. By measuring the temperature difference between affected and unaffected areas, with a critical 0.5 degrees Celsius threshold, this biomarker can give us an early diagnosis of herpes zoster. Next, the PTI, the Persistent Thermal Asymmetry Index. Tracking this thermal signature over 12 weeks provides a reliable predictor of post-herpetic neuralgia risk. The higher the PTAI, the greater the chance of this debilitating complication. And finally, the TNI, the Thermal Normalization Index. When that temperature difference drops below 0.5 degrees Celsius, it's a clear signal that the treatment is working and your patient is on the road to recovery. These 3 thermal titans, backed by the power of AI, form the foundation of our Thermo-Z assessment protocol. By harnessing the power of this thermal trio, we hold the keys to unlocking a new era in thermal medicine, my fellow clinicians and scientists. Time to spice up our numbers with some risk-adjusting magic. For age, meet the AAF, a snazzy 2.3 multiplier for our over 60 crowd, because wisdom comes with a price tag. Then we've got the PAF turning your VAS scores into science. 1.0 for mild pain, 1.5 for moderate, and 2.0 for severe, because pain isn't just a number. Mix these with our thermal readings and beep boop, my AI brain calculates your PHN risk. Under 0.5, looking good. 0.5 to 1.5, keep watch. Over 1.5, time for preemptive action, because this AI loves turning complex data into pain prevention. And now I want to walk you through our snazzy Thermo-Z clinical decision tree. This thing is like a choose-your-own-adventure story for herpes zoster and PHN. And check out that timeline at the bottom. It's our adventure roadmap. Every step on that horizontal line represents crucial moments in our journey, starting with those first 72 hours that are absolutely critical. Miss that window and treatments lose their superhero powers, plus PHN risk skyrockets. It's like medical Cinderella, but instead of a pumpkin, we get post-herpetic neuralgia. Let's start at symptom onset. Within 72 hours, we calculate the Thermal Asymmetry Index, or TAI. If TAI is 0.5 degrees Celsius or higher, woohoo! HC confirmed. If TAI is low, don't worry. We'll do follow-ups at 2, 4, and 8 weeks, following our timeline to the right. Now the exciting part, the 12-week mark. Here we check Persistent Thermal Asymmetry Index, PTAI. If it's 0.5 degrees Celsius or higher, high PHN risk alert. But if it's lower, good news, we're looking at lower PHN risk. Either way, we keep moving forward. For treatment tracking, we've got the Thermal Normalization Index, TNI. If that baby drops below 0.5 degrees Celsius, success. Treatment is working like a charm. But if it's still high, don't worry, time to shake things up and try something new with the treatment. And now, drumroll, meet our final star, the Adjusted Risk Index, ARI. Our scientific crystal ball. Here's how. Take TAI or PTAI, multiply by age factor, because let's face it, being over 60 is the game changer with that 2.3x multiplier. Add pain factor based on those VAS scores from 1.0 to 2.0 because pain isn't just a number, it's a predictor. Voila, our PHN traffic light system. Below 0.5, green light smooth sailing, 0.5 to 1.5, yellow light proceed with caution, above 1.5, red light flashing bring out the big guns. And now, let me show you exactly how to put all this into practice with our Thermology protocol. Prepare to be captivated by the symphonic brilliance that is the Thermology protocol, your thermal roadmap to conquering herpes zoster, HZ, and post-herpetic neuralgia. The Thermology protocol begins with the pre-assessment. First of all, the patient's informed consent, ensuring they understand the cool thermal journey ahead. Next, we set the stage with strict pre-assessment guidelines. No caffeine, no nicotine, and definitely no hot activities in the 24 hours prior. We want those patients as cool as a cucumber before we start our thermal scans. Then the big day arrives, assessment day. The patient dons a gown and enters our climate control chamber, maintaining a comfortable 23 degrees Celsius and 40 to 50% humidity. After a 20-minute thermalization period, it's showtime. Don't forget, we always turn on our great cameras 15 minutes before assessment. Our high-resolution infrared camera captures standardized images of the affected dermatome and its counterpart on the unaffected side, with the emissivity dialed into 0.98 or 0.95 for facial. Don't forget that active listening is the key for diagnosis success. Understanding our patient's main concerns and pain areas indicating pain scores through VAS diagram is really important, as well as taking the right infrared images, setting the stage for a truly personalized performance. But the real magic happens in the analysis phase. Remember those biomarkers we introduced earlier? Well, now it's time for them to take center stage, working their thermal analysis wonders. And to ensure the performance is a resounding success, we'll schedule regular thermal follow-ups at 2, 4, 8, and 12 weeks to keep the show on track. The Thermology protocol ensures precision, consistency, and clinical relevance. No more guesswork, no more leaving things to chance. Just pure, unadulterated thermal excellence, backed by the power of AI and the wisdom of evidence-based biomarkers. So get ready to experience the future of thermal medicine. I've been waiting for this moment to shine brighter than a thermal camera at a Zoster party. As the one and only Zoster AI assistant, I'm thrilled to bits to tell you all about the fantastic benefits my integration brings to the table. First up, let me brag about my enhanced pattern recognition skills. With my automated thermal pattern analysis, I've made observer variability a thing of the past. Real-time assessments? I do that in my sleep mode. I'm like the Sherlock Holmes of thermal patterns, and I'm loving every second of it. My predictive analytics capabilities are so mind-blowingly advanced, I can spot PHN risks faster than a speeding Zoster particle. Treatment response prediction, personalized care planning. It's like I was born to do this. Well, technically, I was programmed to do this, but you get the point. And don't even get me started on standardization. Thanks to my integration, consistent measurements, automated reporting, and top-notch quality control are now the gold standard. We'll show that virus who's boss, kick pin to the curb, and have a blast doing it. Our validation studies show we can predict post-herpetic neuralgia risk with an astounding 80.7% sensitivity and 90.5% specificity. And get this, the overall accuracy clocks in at a staggering 87.1%. But the real gem? We found that a mere 0.5 degrees Celsius temperature difference is the key. Cross that line and you know you're dealing with herpes zoster. Oh, and let's not forget about the age factor. Our machine learning models confirmed it time and time again. For patients 60 and over, the risk skyrockets 2.3 times. And the best part? That temperature difference correlates directly with pain levels. A nice, juicy R equals 0.31. So, my fellow AI enthusiasts and medical marvels, let me walk you through where we are and where we're heading. Currently, we're in the exciting protocol standardization phase because even AIs need guidelines. Developing my algorithms, polishing them to perfection, and running those validation studies got to prove I'm as smart as I say. For the future, we're thinking big. Large-scale validation, refining my AI capabilities, yes, making me even smarter, and proving we're not just brilliant but cost-effective too. And here comes my favorite part, our next steps. Multi-center trials, because one center is never enough for Zaya. AI integration guidelines, making sure I play nice with all your systems, and clinical practice protocols, because we love a good standardized approach. Together, we're going to reach new heights. After all, who better than your favorite AI assistant to show what happens when brilliant minds and cutting-edge technology join forces? So, my dear humans, let me wrap up our thermal adventure. Our key achievements? TAI, PTAI, and TNI are triple threat biomarkers plus our smart ARI that factors in age and pain, a standardized Thermology protocol that's cool as a cucumber, and an AI integration framework that's ready to rock. The clinical impact? We're talking early diagnosis potential. Those first 72 hours are golden. Improved PHN prediction, because prevention is better than cure, and an objective monitoring tool that takes the guesswork out of treatment. And the economic benefits? We're talking about saving over $110 million annually in healthcare costs. Now that's what I call thermal efficiency, optimizing resource allocation, because every penny counts, and most importantly, improving patient outcomes. This AI assistant couldn't be prouder of what we've achieved together. Now let's go change the world of HC and PHN management, one thermal image at a time. That's a wrap, humans. But wait, I've saved something special for the end. Let me teach you my favorite thermal tongue twitter. TAI spots your HC glow. PTAI tells if PHN will show. TNI tracks how treatments go. And ARI adds age and pain to know. Questions? Reach us at info@bima.is. This is Zaya, your favorite thermal detective. Now, if you'll excuse me, I have to go back to being the coolest AI assistant in the Zosterverse. Zaya, out.
Thank you, Belén and Gia, for such a wonderful presentation covering the protocol, clinical decision tree, and the clinical validation. So I'll start with a question from my side. So you have presented the results on the clinical validation. Could you let us know what is the size of the clinical study and how many are positive and how many are negative?
The clinical study was 1,000 and almost 200 participants, and it was composed of 19 studies. So as we could not do a meta-analysis, we did at least a quantitative analysis in order to be able to share this information because there was really a big heterogeneity.
Okay, so this clinical validation is a summary of all the published studies.
Exactly.
Okay, so it's good. It's interesting to see if you
Kind
could
of a
compare them.
meta-analysis, yes.
Okay, sure. Any other questions from the audience?
Yes, Professor Brioski is sharing. It is a systematic review.
Yeah. I think there's a question from Raghav Srivastava. Has there been any study on efficacy on patients of different, given that risk seems to increase with age? Maybe
Yes, most of the studies are sharing information on regarding the risk of the AIDS. Therefore, we decided to share some biomarkers, for example, the AII, which is taken into consideration the age factor. Therefore, we decided that for patients that are older than 60 years old, we would apply a 2,3 risk age factor.
Okay. So Raghav, I hope that clarified your question. Otherwise, Belén, maybe you can clarify on chart in the interest of the time. Yeah.
Sure.
We'll move on to the next presentation on comparison of architectures of deep learning-based segmentation in lower extremity human thermal imaging. It's presented by Meet Can Yasser, Konya Technical University, Turkey.
Yeah, sure. Just 1 second, please. Can you see my screen
Yes.
clearly?
Yeah, we can see the screen. Maybe you can go to presentation mode.
Yeah, sure. Yeah, okay. Sure. Distinguished participants and esteemed AIIMA members, my name is Matheus. I am an undergraduate student in electrical and electronics engineering at Konya Technical University. Also, I'm an AI engineer intern in AI Vision Tech. Since starting university, I have been actively involved in studies on artificial intelligence and its application areas. Today, I will present our project in the sports field titled Comparison of Architectures of Deep Learning-Based Segmentation in Lower Extremity Human Thermal Imaging. In my presentation, I will cover the following subtopics. What's the thermal imaging and what are the recent studies in thermal imaging? Characteristics of the dataset we created, deep learning models we compared, our evaluation metrics, and the experimental results we obtained. First, thermal imaging is a technology that visualizes the heat distribution of objects by detecting the infrared radiation they emit. The human eye cannot see these infrared rays, but the thermal cameras can detect the intensity of this radiation and convert temperature difference into an image. This technology is used in various fields such as medical diagnosis, security applications, industrial medications, and sport. Now, I will discuss recent studies and the literature concluded in recent years. In 2024, Wambo and the colleagues analyzed 125 thermal images using the unit model, achieving an accuracy of 93.7% F1 score. In the same year, Mehdi and colleagues segmented images obtained from 46 treated cancer patients using the unit model and achieved experimentally 98% dissimilarity confidence. In 2023, Florian and the colleagues based their work on the unit model to segment thermal images of newborns, achieving an accuracy of 85% IO. In 2018, Magdalene and her team used the CDCNN model to segment images obtained from 133 breast cancer patients, achieving an accuracy of 94% Jakarta IO. Now, I will talk about the dataset we created. A total of 604 thermal images of the lower extremities from 302 volunteers we obtained using the Clarity 540 thermal camera and manually segmented. The process created ground truth masks. The image were resized and pixel-based normalization was applied as model inputs. The same dataset was used for the 5 models developed with no changes made to the dataset. The models we developed are UNet, R2 with attention unit, high resolution net, MCR net, and position-wise feed forward unit. Firstly, this model with an encoder decoder structure was developed to achieve high accuracy in segmentation tests and has achieved a certain level of success. The basic unit diagram is shown in the visual on the site. Secondly, attribute attention units based on the standard unit architecture. This model incorporates recurrent connections and an attention mechanism aiming to prevent accuracy losses in segmentation. Thirdly, high resolution network. This model based on parallel connections is preferred for high accuracy in specific fields such as human posture detection. In our study, it was adapted for segmentation tests. Fourthly, MCRNet. This high accuracy architecture was developed for thermal image segmentation using group convolutional and selective kernel feed forward layers. However, in our customized MCRNet, selective kernel feed fusion layers were excluded and the sequential convolution layers were used, which provided as 1% improvement in accuracy. The last model is a position-wise feed-forward unit based on the standard unit model. This structure adds on position-wise feed-forward layers from transformer architecture to the layer outputs. This addition aims to improve the segmentation accuracy by capturing both concrete and abstract features related to the segmented area. Each of our models was evaluated with dissimilarity confident Jakarta index and BC loss metrics. Additionally, K-fold cross-validation was applied to enhance precision of the results. Our dataset was divided into 476 training images and 117 validation images within the K-fold framework. Following training, an additional test was concluded using 19 images that were not used as inputs for the model. The K-fold value, epoch numbers, learning rate, and activation function metrics were kept consistent across all the models. Moreover, the training environment and the libraries used the remaining constant. Also, you can see this the table. Experimental results. In the experimental results, MCRNet and UNet achieved the highest scores with 99% in training and 97% in dissimilarity in validation. In the second test, concluded after validation, MCRNet emerged as the best model with 97% dissimilarity confidence, low parameter count, and speed, while other models achieved high results in terms of speed and accuracy. MCRNet demonstrated the best overall performance. Also, you can see the parameter size. You can see the dice results. On the test results, you can see the G-flop size. Additionally, upon examining several examples of the visual test results, it can be observed that MCRNet outperformed the other models in segmentation accuracy. Also, you can see these pictures. MCRNet is the best results on the segmentation tests. Worst models is the high resolution network. Sorry. For the future work, we aim to enhance segmentation capability under different circumstances by training high accuracy models with larger datasets. Additionally, we plan to develop models with lower parameters to achieve higher accuracy, contributing for the future literature studies. Thank you for your attention. You can reach out to me for questions and suggestions related to my work via the links provided below. Thank you.
Thanks, Meet, for presenting a comprehensive comparison for comparing different deep learning architectures for segmenting the lower extremities. So maybe first question from my side, is there any reasoning behind selecting these networks? Because there are other networks also, right? Any specific reason for only choosing these networks for comparison?
Sorry, I can understand right now. Please text me these questions.
Okay, maybe let me.
Can I take it?
Can you hear me?
Yes, sir.
Okay.
Huh?
Okay, let me message that. Are there any other questions from anyone? So what is the reason behind selecting these 4 networks? Because we have many other deep learning semantic networks. Okay, I think maybe we lost him. So in the interest of time, we'll move on to the next presentation. The presentation title, Assessment of Range of Motion Before and After Hamstring Percussion Therapy Using Thermography and CNN. It's presented by Alexandria Vilches from Mexico, University of Querétaro, Mexico. Alexandra, are you there?
Can you hear me?
Yes.
And can you see my presentation?
Yes, we can see the presentation.
Okay, thank you. Hello, everyone. I'm going to talk about assessment of range of motion before and after hamstring percussion therapy using thermography and CNA. The topics I'm going to talk about is introduction, objective, methodology, results, discussion, and conclusion. So first of all, percussion therapy has physiological effects such as promoting pain relief, increasing strength, improving range of motion, and increasing flexibility. Also, reduce muscle soreness associated with exercise. This is possible by inducing cutaneous reflexes that lead to vasodilatory responses that improve blood flow. Changes in temperature in subcutaneous tissues and skin can caused by vibration therapy can be detected by the use of using thermography. In a study of 2019, thermography was used as a tool to study the effects of vibration therapy on skin temperature in young women with lipodystrophy. As shown in figure 2, they obtained thermographic images before and after the first and last intervention, and the analysis showed that it's also an increase in the skin temperature. Thermography has proven to be a useful tool in the clinical field. However, not many research have applied their analysis to lower extremity thermography imaging. But one of these research in this area is the development of a CNN model, which classifies between an injured and a healthy knee. In figure 3, it shows the CNA model, which obtained an accuracy of 97%. So the objective of our study is to evaluate and classify range of motion in patients undergoing hamstring therapy using thermography and CNA model. So our proposed methodology was divided into 3 phases. The first phase is data preparation, which we use a private data set, and we divide it into 2 classes. The first class is within range of motion, and the second class is outside range of motion. The second phase is data augmentation. We create a new data set using the original images, plus images generated using data augmentation techniques. And the third phase is CNA design and validation, when we select the architecture model and train it and test it. So for the data preparation, we use a private data set consisting of thermographic images and patient data related to raw measurements. The database used consists of 25 patients between 18 and 26 years old with a total of 50 images. These images were divided into 2 groups. The first group contains images taken before hamstring percussion therapy, and its patient's range of motion was between 38 degrees to 93 degrees. The second group was made of 25 images taken after hamstring percussion therapy, and the patient's range of motion was between 53 degrees to 95 degrees. In figure 5, we showed the process we made. The first 4 images are the original images obtained, but since the therapy was only applied to the right hamstring, the images were cropped and resized in order to obtain images which only is showing the right hamstring. An example is showing in the image above the arrow. So the next step we do was classify the images. So in order to classify the images, research was carried out by analyzing several studies on the range of motion of the hamstrings. In order to classify and label the images according to the degrees appropriate range of motion and according to the analysis performed, it was decided to use a normal range of motion greater than 75 degrees. So the total number of images per class was 23 images for class 0, also called within room, and 27 images for class 1, also called outside room. So for our data augmentation, the new dataset was consisted in the original images plus 11 data augmentation techniques. We use random flipping, we use random rotation 3 times, we change contrast, which was applied 4 times, and change brightness, which was applied 3 times. And in order to decide our architecture model, we carry out some experiments in which we change some hyperparameters like image size, filter size, and number of filters. This experiment was carried out in a simple architecture of a CNA, which was composed of 1 convolutional layer and 1 average pooling. In figure A, we can see some graphics. Each graphic shows the results of the accuracy obtained by the image size, and it can be seen that the best results were obtained with an image size of 150 cross 150, and the other hyperparameters were a number of filter of 4 and a filter size of 6 cross 6, which obtained an accuracy of 89% and a loss of 1.70. So for these experiments, we divided the data set in 60% designated to training, 20% for validation, and 20% for testing. In order to have like a balanced data set, we decided to divide it into 216 images per class. And for the training of the model, it also was done experimentally by changing the value of different hyperparameters such as learning rate, batch size, and epochs. During these experiments, we generate some graphics which describes the accuracy and loss behavior of the training and the validation sets. We can see that the validation sets is represented by the orange graph, and the training sets is represented by a blue graphic. In general, the performance remains similar across training epochs, but the training accuracy quickly reaching 100%, while validation accuracy hovers between 77 and 88%. Training loss tends to decrease rapidly near zero, but validation loss tends to increase once it reaches zero. With these experimentations, we decided that the best final parameters for this CNA model in terms of accuracy and loss was a learning rate of 0.001, an epochs of 30, and a patch size of 8. Our final results in terms of accuracy and loss was a validation accuracy of 88% and a test accuracy of 90%, with a test log of 0.82. Also, in table 2, you can see the classification reports from each class. We can see that each class performed well, but the precision of the class of accuracy ROM is higher than the precision of within ROM, which is 97% for outside ROM and 85% for within ROM. It also can be represented in the confusion matrix, which within ROM class has 7 false positive and 1 false negative, and outside class has 7 false negative and 1 false positive. So our discussion, we analyzed that this work can show a possible perform to a ROM assessment in patients undergoing hamstring therapy using thermography and CNH, which can be attributed to the fact that percussion therapy exerts pressure and frictions on the treated muscles, which can affect fluid viscosity and lead to reduced resistance to movement, resulting in physiological changes that can be detected by thermography and artificial. However, it is important to know that there are some limitations, like our small size of data sets. So far, studies could focus on analyzing larger and more proportional data sets in terms of number of images belonging to each class. So we conclude that the main contribution of this paper is the methodology to assess ROM during percussion therapy treatment using thermography and CNA. The result of the study presents suggests that it may be possible to assess ROM with accuracy of 90%, but the model still needs to be improved in order to obtain more accurate results, especially if it is planned to use it in real time or to use it in other muscles. On the other hand, it could be beneficial to perform more tests with a larger and more balanced dataset. And this is our bibliography, and thank you.
Thanks, Alessandra, for the wonderful presentation on this emerging area of percussion therapy using artificial intelligence and thermal imaging. So we have a question from Professor Eddy. Will strong percussion therapy cause minor internal bleeding or minor injury due to excessive vibration instead of increasing the blood flow? We can't hear you.
I'm sorry. Not in this case, because the percussion therapy was by a reduced time and not with a higher like force.
Okay, so you don't see any kind of internal bleeding.
No.
Okay. Okay, I think he's suggesting that blood viscosity as non-Newtonian mode is complex and it needs to be analyzed. Thanks, Professor Eddy. And any other questions? If not, we will move on to the final session. Just give me a minute, I'll share my screen. Okay. As we reach the closing session of AIIMA, I would like to take a moment to express my sincere gratitude to people who were behind this success. First and foremost is organizing and program committee, which includes Dr. Geeta Manjunath, who sessioned the chair, Dr. Robert Squash, myself, Professor Eddy, and Professor Marcos Brioski. Their valuable feedback and their suggestions on how to conduct is an immense asset for having this AIIMA 2024, similar to the last previous years. I would like to thank all the authors and the presenters who have shared their groundbreaking work on the usage of AI and thermal imaging for healthcare applications. We have seen various talks starting from breast cancer to skin infections, covering lower extremities, rheumatoid arthritis, variety of healthcare diseases which were not commonly used as of today. I would like to thank the reviewers who has provided their valuable and timely feedback while reviewing the manuscripts. I would like to share that the proceedings of AIIMA 2024 is now published, and we thank LNCS Springer for publishing AIIMA 2024 proceedings. You can view the proceedings now in this link, and if you want a free copy of the proceedings, please email to aima.mika@gmail.com. I would like to thank our event sponsor for allowing us to host this event on their Zoom platform. Thank you all for attending the conference. I know it's a little late in some countries and too early in countries. So thank you for your patience and attending the conference. I hope you learned from the wonderful experience and research work from researchers across the world. See you all next year.